Welcome back to the Deep Dive. Today isn't just another deep dive into a random topic. Today we are in full exam mode. We're imagining that you, the listener, are sitting right outside that examination hall, maybe sweating a little in your suit, about to walk in for your MD anesthesiology exams. And we're specifically targeting the rigorous, somewhat traditional standards of the Gujarat University MD exams.
That's right. The pressure is on. The examiners are waiting behind that door. And the topic on the table is one that is an absolute non-negotiable for an anesthetist. I mean, if you mess this up in real life, a patient dies. If you mess it up in the exam, you fail immediately. We are talking about pneumothorax.
Pneumothorax. It sounds basic, doesn't it? Air in the chest. But looking at this stack of books we've gone through, Miller, Morgan, all the ICU protocols, S-DUS, clinical surgery, even Harrison's, there is so much nuance here. So our mission today is to distill all of these, these heavy texts into the perfect long question answer, or a stellar Viva performance.
Exactly. And we're going to structure this precisely how a senior faculty member would expect you to present it. We aren't just chatting. We are building a 10 to 20 mark answer. We have to cover classification, pathophysiology, diagnosis, and most importantly for us, the anesthetic management.
Okay, let's start with the framing then. Why is this topic, as you said, the fail if you miss it topic? Why do examiners love it so much?
Well, because pneumothorax is the archetypal anesthetic emergency. I mean, Miller and Morgan both really emphasize this. In the operating room or the ICU, we are often the ones who cause it through central lines or regional blocks or positive pressure ventilation, and we are the ones who have to fix it, usually in seconds. It compromises both ventilation by collapsing the lung and circulation by causing obstructive shock.
It touches every single part of our physiology. So let's unpack this systematically. Imagine the examiner looks you over their glasses and says, "Doctor, define pneumothorax."
Right. You need a formal definition. Do not give a casual answer here. Based on Harrison's and our notes, you state clearly, pneumothorax is the presence of air or gas in the pleural sac.
Short and sweet.
But you must immediately add the anatomical and physiological consequence that shows you understand the mechanics. You say, this presence of air leads to the separation of the visceral and parietal pleura, resulting in the loss of the normal negative intrapleural pressure. That phrase, loss of negative intrapleural pressure, is the absolute key. It's the fundamental pathology.
Let's pause on that phrase for just a second. We say negative pressure all the time, but for a Viva, we really need to understand the physics behind it. Why is it negative in the first place?
It all comes down to opposing elastic forces. Think of the chest mechanics like a tug of war. The chest wall, your rib cage, has a natural tendency to spring outwards. If you strip the flesh off a rib cage, it would actually expand a little. But the lung tissue is full of elastin and collagen. It wants to recoil inwards like a deflating balloon.
The ribs are pulling out and the lungs are pulling in.
Exactly. And sandwiched between them is the pleural space, which isn't really a space at all, is it? It's potential space with just a tiny amount of fluid. This fluid creates a surface tension. Think of two glass slides stuck together with a single drop of water. You can slide them, but you can't really pull them apart easily. This creates a vacuum or a subatmospheric pressure of about -5 to -8 centimeters of water.
And that vacuum is what effectively couples the lung to the chest wall.
Yeah.
It sticks them together.
Precisely. So when you take a breath, you expand your chest wall. Because of that negative pressure coupling, the lung has no choice but to follow. It expands. But in a pneumothorax, you breach that seal. Air rushes in, the pressure equalizes with the atmosphere to zero, and that coupling is broken. The chest wall springs out slightly, which is why the chest can look fuller on that side, and the lung, following its natural recoil, just collapses down to the hilum.
That is a fantastic explanation, and it explains all the physical signs we'll get to later. Okay, so in terms of relevance, why do we care so much?
It's about incidence and impact. According to Miller, it occurs in about 1% of vaginal deliveries, 2 to 3% of ventilated neonates, and it's a very frequent complication of central venous cannulation. In the ICU, it's a constant threat. The examiner wants to know that you realize this isn't just a respiratory issue, it is a hemodynamic one.
Right. And looking at the past DNB questions we have, this topic really does appear everywhere.
Oh, everywhere. You might get a short note on tension pneumothorax. You might get a clinical scenario like A patient becomes hypotensive following CVC insertion. Discuss. Or, very commonly in the Viva, they will just slap a chest x-ray on the view box showing a collapsed lung and ask you to manage it step by step. You have to be ready for all of these angles.
So we need to be ready for all of that. Okay, let's move to the first major heading of our long answer structures, classification. This is absolutely essential.
Or I cannot just list them randomly. You need a classification tree in your mind. We're relying heavily on ICU protocols and Harrison's for this. The first major branch you talk about is spontaneous pneumothorax.
Which means it happens without any external trauma.
Correct, and you must subdivide that. First, you have primary spontaneous pneumothorax. This occurs in young, apparently healthy adults. Statistically, it's often tall, thin men between 20 and 40 years old without any known underlying lung disease.
The classic tall, thin man. Is it just a stereotype, or is there a reason for that?
No, it's physics again. In tall individuals, the pressure gradient from the base of the lung to the apex is greater just due to gravity. This creates more mechanical stress on the alveoli at the very top, the apex of the lung. Over time, this stress can cause the formation of what we call subpleural blebs.
Blebs, like tiny little blisters on the lung surface.
Exactly what they are, tiny air blisters. And if one of them ruptures, air leaks into the pleural space. And there you have it, a pneumothorax.
Okay, and the second subdivision is spontaneous.
That would be secondary spontaneous pneumothorax. This is where the patient has some underlying lung pathology. The sources list things like COPD, emphysema, tuberculosis, lung abscesses, or even malignancy.
This distinction, primary versus secondary, it feels really important for the exam. Why is that?
It is absolutely vital for prognosis and for management. A healthy 20-year-old with a primary pneumothorax has a huge respiratory reserve. They might just complain of a little bit of chest pain. But a COPD patient with a secondary pneumothorax, they have zero reserve. Even a tiny collapse can cause acute respiratory failure and death. So the management is much, much more aggressive for secondary types.
Got it. So that's the spontaneous branch. What's the other main branch of the tree?
Traumatic pneumothorax. This is the result of blunt or penetrating trauma, car accidents, stabbings, rib fractures. NEET-SS's manual covers this really well. But for us anesthetists, there is a subtype of traumatic pneumothorax that is the most important of all, iatrogenic pneumothorax.
Iatrogenic, meaning doctor-induced.
Unfortunately, yes, or our surgical colleagues. The exam list for causes of iatrogenic pneumothorax is very specific, and you should be able to rattle these off. You need to list central line placement, specifically the subclavian and internal jugular approaches, barotrauma from mechanical ventilation, post-surgical complications, things like nephrectomies, tracheostomies, CPR is a big one, and do not forget regional anesthesia.
Which blocks are we talking about specifically?
The big ones are the supraclavicular and paravertebral nerve blocks. We'll dive deeper into those later, but you have to mention them in your classification.
Okay, so we've covered spontaneous and traumatic, but there's one more type that sort of sits across all these categories, right? The one that scares everyone.
Tension pneumothorax. Now, you have to pay close attention here. In the exam, if you define tension pneumothorax solely by its X-ray findings like mediastinal shift, you could lose marks.
Really? Why? I always thought mediastinal shift was the definition.
Mediastinal shift is a sign, a very important sign, but it's not the core definition. As S-DOS and the ARC guidelines emphasize, tension pneumothorax is defined by its adverse effects on cardiovascular function. It is a physiological state, not just an anatomical one. It's what happens when air enters during inspiration but cannot exit during expiration because of a valvular leak. This leads to a progressive pressure buildup that crushes the heart and great vessels.
That is a critical distinction to make. Tension is about the shock, not just the air.
Precisely. You can have a tension pneumothorax with a relatively small amount of air if the pressure builds high enough to impair venous return. It's all about the pressure.
Okay, fantastic. We have our classification down. Now we need to explain why this kills the patient. Let's move to Part C, pathophysiology. This is where we show the examiner we really understand the mechanisms. This is exam gold.
Let's start with the simple pneumothorax. We already discussed the mechanics of the collapse, the loss of that negative pressure, but what does that do to gas exchange?
This is where the VQ mismatch concept comes in.
Right. V is ventilation, Q is perfusion. In a collapsed lung, the alveoli are all deflated. They aren't getting any fresh oxygen, so ventilation is effectively zero. But the heart is still pumping blood to that lung through the pulmonary artery. Perfusion is relatively normal, at least initially, so your V divided by Q is zero.
And we call that a shunt.
Correct. It's a right-to-left intrapulmonary shunt. Deoxygenated blood passes through the collapsed lung, picks up no oxygen at all, and then dumps straight into the left atrium, diluting all the nice oxygenated blood coming from the healthy lung. This is what causes the systemic hypoxemia.
But the body is clever. It has a defense mechanism for this, doesn't it?
It does. It's called hypoxic pulmonary vasoconstriction, or HPV. The pulmonary arterioles in the bad lung, they sense the low oxygen level in the alveoli, and they reflexively constrict, they clamp down. This increases the vascular resistance in the bad lung and forces the blood to divert over to the healthy lung where it can actually get oxygenated. It's a brilliant survival mechanism. It reduces the blood flow to the collapsed lung by about 50%.
And here is where the anesthesia relevance kicks in. This is the gold point for the Viva.
This is it. Miller and Yao and Artuzio point out that our volatile anesthetic agents, our gases like sevoflurane, isoflurane, dysflurane, are potent vasodilators. They directly inhibit this HPV mechanism.
So if you have a patient under anesthesia with a pneumothorax, the anesthetic gas relaxes those constricted vessels, blood flows right back into the useless lung, and the shunt gets way worse.
Exactly. A patient under general anesthesia with a pneumothorax will be significantly more hypoxic than an awake patient with the exact same size pneumothorax. That is why it's so dangerous in the operating theater.
That is a very high yield point. Now let's dial up the intensity, the pathophysiology of a tension pneumothorax. We mentioned the one-way valve.
This is very, very high yield. You have to be able to describe the mechanism clearly. A flap of damaged tissue, either on the lung surface or on the chest wall, acts as a check valve. Air gets sucked into the pleural space when the patient breathes in because of the negative intrathoracic pressure. But when they breathe out, the pressure becomes positive, and that little flap of tissue slaps shut. The air is trapped.
So the volume of air in the chest grows with every single breath.
It grows and the pressure rises. The intrapleural pressure, which should be negative, becomes positive, +10, +20, +30 centimeters of water. It just keeps rising.
And this is what leads to what Estes calls obstructive shock. Can you walk us through the steps of that collapse? I want the listener to really visualize the anatomy being crushed.
It's a domino effect. Step 1. The massive pressure in one side of the chest pushes the entire mediastinum, that's the heart, the great vessels, the trachea, over to the opposite healthy side. We call this the mediastinal shift.
Which you can see on an X-ray, usually.
If you wait for one, yes. Step 2. This shift in compression limits the expansion of the healthy lung. So now you have one collapsed lung and one squashed lung. The respiratory failure gets dramatically worse. Step 3, and this is the absolute killer, the kinking of the great vessels, specifically the vena cava.
The superior and inferior vena cava. They're thin-walled veins, right? They aren't rigid like arteries.
Exactly. Think of them like a garden hose. If you step on a garden hose, the water stops flowing. The incredibly high intrathoracic pressure steps on the vena cava and flattens them.
So venous return to the right side of the heart just stops. It drops to zero.
If there is no venous return, there is no preload. If there is no preload, there is no cardiac output. The heart is beating, but it's pumping empty. This leads to profound hypotension and eventually pulseless electrical activity, a PEA, cardiac arrest. That is why it is an immediate threat to life.
That description of the vena cava kinking is so memorable. Okay, so how do we spot this coming? Let's move to clinical features and diagnosis.
The exam requires you to be systematic. Inspection, palpation, percussion, auscultation. Estos's manual is the Bible for this section, and examiners expect you to recite it in that order.
Okay, what are we seeing on inspection?
Well, the respiratory distress is obvious: dyspnea, tachypnea, cyanosis. But you have to look at the chest mechanics. You'll see reduced chest movement on the affected side. It looks still. And because the ribs have sprung out a bit due to that loss of negative pressure, that side might actually look larger or fuller.
The palpation.
Tracheal deviation. This is the classic sign. In a significant pneumothorax, and definitely in tension, the trachea is pushed away from the affected side. You feel for it in the suprasternal notch. You also should assess for subcutaneous emphysema, that crackling Rice Krispies feeling under the skin.
Percussion.
This is a classic Viva question. The note will be hyper-resonant. It sounds like a drum because you're tapping on a chest that's full of air. This is key to distinguishing it from a hemothorax or a pleural effusion, which would be dull or stony dull on percussion.
And finally, auscultation.
Absent or significantly diminished breath sounds on that side. It's silent.
Now, for tension pneumothorax specifically, are there cardiovascular signs we need to be looking for on top of those?
Yes. Remember, tension is a hemodynamic diagnosis. You look for tachycardia and hypotension. And here is a key clinical sign mentioned in Morgan and the ICU protocols: Distended neck veins.
Right, because the blood is backing up, trying to get into the heart, but it's
Eh.
blocked by that kinked vena cava.
Exactly. And this raises an important differential diagnosis question that examiners absolutely love. What else causes distended neck veins and hypotension?
Cardiac tamponade.
Correct. Both tension pneumothorax and cardiac tamponade present with distended veins and shock. This is a very common exam trap. How do you tell them apart clinically, right there at the bedside, without an echo?
I would guess it comes back to the percussion and the breath sounds.
Precisely. In tamponade, the lungs are usually clear, the breath sounds are present bilaterally, and the percussion note is normal. In a tension pneumothorax, you have that hyper-resonant note and the absent breath sounds on one side. The ARC guidelines really highlight this differentiation.
Okay, so let's talk about confirming the diagnosis.
You have to be so careful here. The expert rule, emphasized in SDACE and all the ICU protocols, is tension pneumothorax is a clinical diagnosis.
Meaning what, exactly?
Meaning you do not wait for an x-ray. If the patient is crashing, if they have a deviated trachea and a silent chest, you put a needle in their chest. If you send a patient with a tension pneumothorax to the radiology suite, they will die in the elevator. And you will fail the exam, period.
But for a stable, simple pneumothorax, we do use an x-ray.
Yes. On a standard erect film, you're looking for the visceral pleural line, a thin, sharp, white line. Distal to that line, out towards the chest wall, there are no lung markings. It's just jet black.
What about in the ICU context, where the patient is almost always lying down? Does a supine x-ray work as well?
The ICU book warns us about this. It's just basic physics, right? Air rises. In an erect patient, air goes to the apex of the lung. In a supine patient, air rises to the front, to the anterior chest wall.
So it just sort of spreads out over the front surface of the lung.
Exactly. It doesn't form that nice apical line that's so easy to see. A standard supine film might miss 50% of pneumothoraxes. You have to look for more subtle signs, like the deep sulcus sign. The costophrenic angle at the bottom looks abnormally deep and dark because air is collecting down there anteriorly.
This brings us to the new standard of care, which the examiners are starting to ask about more and more. Ultrasound, or PCUS?
Yes. Point of care ultrasound. The lung UCG PCUS source is excellent on this. You need to know the terms. Normally, the ultrasound beams reflect off the pleura. In a normal lung, the visceral and parietal pleura slide against each other with every breath. It looks like shimmering ants. We call this lung sliding.
Right, ants marching on a log.
That's the one. Or if you put it in M mode, it creates this grainy pattern on the bottom and straight lines on the top. It looks like a beach and the ocean. We call it the seashore sign.
And if there's a pneumothorax, what happens then?
The air gets between the layers and separates them. The sliding stops completely. The ants stop marching. In M mode, the grainy seashore disappears and it all becomes straight horizontal lines. This is the barcode sign or the stratosphere sign. It means there is absolutely no motion at the pleural interface.
And is there a specific sign that confirms it 100%?
The lung point. This is the physical spot on the chest wall where the pneumothorax ends and the normal lung begins. As the patient breathes, you can actually see the transition on the screen. You see sliding, then no sliding, sliding, then no sliding. If you can find a lung point, it is 100% specific for pneumothorax.
That's fantastic.
Yeah.
What about B-lines?
B-lines, those vertical comet tail artifacts, they arise from the visceral pleura. So if you see B-lines, it means the visceral pleura must be touching the parietal pleura. Therefore, there is NO pneumothorax in that specific spot. B-lines effectively rule it out.
Okay, we've diagnosed it. Now let's get to the absolute core of our specialty. Part E, anesthetic implications. Why is a pneumothorax such a nightmare for an anesthetist?
It comes down to one thing, pressure. Spontaneous ventilation is negative pressure breathing. Mechanical ventilation, IPPV, is positive pressure breathing.
So if I have a patient with a small, maybe undiagnosed pneumothorax, say a trauma patient, and I induce anesthesia and start ventilating them, what happens?
You are forcing air into the lungs under pressure. If there is a hole in the pleura, you are actively pumping air into the pleural space with every single breath. You are essentially inflating the pneumothorax like a tire. You can instantly convert a stable, simple pneumothorax into a life-threatening tension pneumothorax. Morgan calls this out as a critical danger.
And that would present as sudden cardiovascular collapse right after induction.
Exactly. If the blood pressure clashes the moment you start bagging or the ventilator takes over, pneumothorax must be at the very top of your differential diagnosis.
We also talked about iatrogenic causes. Let's just run through the list of intraoperative causes we need to be hyper aware of.
Central venous cannulation is number 1. The incidence is 1 to 4%. The subclavian approach is riskier than the internal jugular. The apex of the lung actually rises above the clavicle, so if your needle goes too deep or too steep, you can puncture it.
What about regional anesthesia?
Supraclavicular blocks, we call it the spinal of the arm, but historically it was known as the pneumothorax block. The pleura is millimeters away from the brachial plexus there. Even with ultrasound, if you lose your needle tip for a second, you can puncture the lung. Paravertebral blocks carry a risk too.
And then there's the equipment itself, barotrauma.
Right. If your airway pressures are set too high, or if the patient coughs or breath holds against a closed glottis, alveoli can rupture. Also, equipment malfunction like a stuck APL valve or accidentally hitting the oxygen flush valve when the circuit is occluded. That sends a huge blast of high-pressure gas straight into the lungs.
And laparoscopic surgery, I remember that being a cause.
Yes, we pump the abdomen full of carbon dioxide. If there are congenital defects in the diaphragm, that CO2 can track up into the chest, causing a pneumothorax or a capnothorax. You'll see your airway pressure suddenly climb and the blood pressure fall.
This is the part where the examiner leans forward and asks, "So doctor, what are you going to do about it?"
Let's talk management. We need to divide this into simple intention. Simple pneumothorax first.
If it is small, and that's usually defined as less than 15 to 20% of the hemothorax, and the patient is asymptomatic and stable, the ICU protocol suggests you could just observe them with high-flow oxygen.
Why the oxygen specifically? It helps reabsorb the nitrogen from that air pocket in the chest. It creates a steep diffusion gradient for nitrogen to move out of the pleural space and into the blood. It can speed up the resolution by about 4 times compared to just room air.
But there's a massive, massive caveat for us as anesthetists, isn't there?
A huge caveat. If that patient needs general anesthesia and IPPV for surgery, you cannot just observe. It doesn't matter how small it is. You must insert a chest drain before you induce anesthesia. You cannot safely ventilate a patient with an undrained pneumothorax because of that risk of tension we just discussed.
That's a very clear rule. Now, the big one. Tension pneumothorax. The patient is crashing. What is the algorithm?
The algorithm from SDOS and the ICU protocols is strict, and you must recite it. 1, immediate recognition. 2, immediate decompression. Do not wait for an X-ray. 3, needle thoracostomy.
Okay, where do we put the needle? This is a point of contention in modern practice.
It is. But for the purpose of this exam, and sticking to the provided sources like SDOS, you state a wide-bore cannula, a 14-gauge, that's the orange one, in the second intercostal space in the mid-clavicular line.
Now, I know the newer ATLS guidelines have moved towards the fifth intercostal space in the anterior axillary line because the chest wall is often thinner there, especially in obese patients. Should we mention that?
I think it's smart to acknowledge it. It shows you are well-read. You can say something like, while recent ATLS guidelines suggest the fifth space, standard surgical texts like SDOS recommend the second ICS in the mid-clavicular line. In a traditional exam like the one at Gujarat University, it's safest to stick to the textbook unless the examiner pushes you on it.
And when you put that needle in, what happens?
You should hear a hiss of escaping air, a rush of air. That confirms the diagnosis and immediately relieves the tension. The patient's blood pressure should start to improve almost instantly.
And is that it? Are we done then?
Absolutely not. That just buys you time. A needle is only a temporary fix. It can easily kink or get blocked by tissue. The definitive management is a tube thoracostomy. That is, inserting a proper intercostal drainage tube, or an ICD tube, and connecting it to an underwater seal.
Let's talk about that underwater seal for just a second. How does that actually work? It's a simple but brilliant device.
It's a one-way valve made of water. You have a tube coming from the patient's chest that goes into a bottle of sterile water. The tip of the tube is kept about 2 centimeters underwater. When the patient breathes out or coughs, the positive pressure in their chest pushes air out. It bubbles through the water and escapes from the bottle. But when the patient breathes in, they create negative pressure, and water gets sucked up the tube a little bit, but air cannot go back up the tube and into the chest. It prevents air from re-entering.
Okay. Now let's talk about the specific anesthetic management of a patient who has a pneumothorax. Let's say it's been drained or we're managing it intraoperatively. What drugs or gases must we avoid?
Nitrous oxide, N2O. This is the black box warning of anesthesia in this situation.
Why is that?
It's physics again. It's Fick's law of diffusion. Nitrous oxide is 34 times more soluble in blood than nitrogen is.
Okay, can you explain that in simple terms?
The air pocket in the chest is about 80% nitrogen. Nitrogen is not very soluble, so it doesn't want to leave the blood easily. But nitrous oxide loves to leave the blood and rush into any air-filled space in the body. So if you turn on 50% nitrous, a huge volume of nitrous molecules will flood out of the blood and into that pleural pocket. Nitrogen can't leave fast enough to make room for it.
So the total volume of gas in the pocket increases.
Rapidly. The Doctor Podcast scripts and pharmacology GARG sources note that it can double the size of a pneumothorax in just 10 minutes. If it's a closed space, the pressure will skyrocket.
So N2O is absolutely 100% contraindicated.
Absolutely. If you say you'd use it in the exam, you fail. Simple as that.
What about our ventilation strategy for these patients?
You want to be gentle. A lung protective strategy. Use low tidal volumes. Limit your plateau pressures. You want to avoid forcing more air through the leak in the lung. If there's a chest drain in situ, you have to watch it like a hawk. If it's bubbling vigorously with every single breath, that tells you there is a large ongoing air leak, a bronchopleural fistula.
And what about PEEP? Positive end expiratory pressure.
You have to be very careful. PEEP, by its nature, increases intrathoracic pressure and can push more air out through the leak. It can also prevent the hole from healing. Miller suggests minimizing PEEP if at all possible. Also, if you can, try to maintain spontaneous ventilation during induction to avoid that initial spike in positive pressure that could make things worse.
Let's move on to the ICU and post-op setting.
Right. In the ICU, we are always worried about ventilator-induced lung injury, or VILI. We are often pushing air into very stiff, diseased lungs like in ARDS. High pressures cause barotrauma, or just high volumes cause volitrauma from overdistension. The ICU book highlights that patients with ARDS are at an extremely high risk of pneumothorax because they often require high levels of PEEP just to stay oxygenated.
I've heard the term occult pneumothorax used in the ICU. What is that?
That's a small pneumothorax that wasn't seen on the initial admission X-ray. Maybe it's sitting anteriorly and was missed on a supine film. The patient is stable. But then their pneumonia gets worse and you have to intubate them. You apply positive pressure ventilation. Suddenly, that small occult pocket expands massively under the pressure and becomes a tension pneumothorax.
So if a patient suddenly crashes right after being intubated in the ICU...
You have to think about pneumothorax immediately. It's a top differential.
And what about in the post-anesthesia care unit, the PCU?
You have to be very suspicious of the patient who just had a central line put in during surgery or a patient who's had neck surgery, like a thyroidectomy.
A thyroidectomy. Why is that a risk?
Because the pleura extends up above the clavicle. We call it the pleural dome or cupola. During a difficult thyroid dissection or a radical neck dissection, it's possible for the surgeon to nick the pleura. If that patient is restless or hypoxic in the recovery room, don't just reach for the sedatives. You have to rule out a pneumothorax. Grab the ultrasound probe.
This is great. We're in the home stretch now. Let's consolidate all of this for the exam. The comparison tables are very high yield for written answers.
Yes, you need to be able to rattle off the differences between a simple and a tension pneumothorax in a table format. Simple pneumothorax, trachea is central, hemodynamics are stable, percussion note is increased resonance, tension pneumothorax, trachea is deviated away from the lesion, shock, meaning hypotension and tachycardia, is present, neck veins are distended, percussion note is hyper-resonant.
And now, my favorite part, the traps, the questions the examiner asks specifically to trip you up.
Trap number 1. Doctor, you suspect a tension pneumothorax. The X-ray tech is just down the hall. Do you send the patient for a quick film to confirm? The answer is an emphatic NO. You state. Tension pneumothorax is a clinical diagnosis requiring immediate needle decompression. I would not wait for radiological confirmation as this would fatally delay treatment.
Perfect. Trap number 2. Can you use nitrous oxide if the patient has a functioning chest drain in place?
The answer is still no. The safe, exam-approved answer is NO. You can explain that theoretically, if the drain is working perfectly, it might be okay. But the risk of the gas expanding faster than the tube can drain it is far too high. It is an unnecessary risk, so it should be avoided.
Excellent. Trap number 3. How do you distinguish a large bullet and air pocket inside the lung from a pneumothorax on a chest X-ray?
This is a tricky one, because if you stick a needle in a giant bulla thinking it's a pneumothorax, you pop the lung and cause a massive air leak, a bronchopleural fistula. The answer is that a CT scan is the definitive investigation. You can mention that on an X-ray, a pneumothorax usually shows a thin, visceral pleural line that is convex towards the chest wall. A bulla often has a wall that is concave or rounded differently, but if there is any doubt, you get a CT scan before intervening.
Finally, for the written exam, Diagrams are essential, aren't they?
You must draw diagrams. They get you extra marks every time. 1. Draw the one-way valve mechanism, showing air entry during inspiration but no exit during expiration. 2. Draw the triangle of safety for chest drain insertion. You label the borders, the lateral border of pectoralis major, the anterior border of latissimus dorsi, and the 5th intercostal space. And if you are discussing ultrasound, drawing the barcode sign versus the seashore sign shows you really know your stuff.
Let's summarize the absolute take-home exam points, the bullet points they need to have memorized.
Okay. Number 1. The definition of pneumothorax is the loss of negative intrapleural pressure. Number 2. The diagnosis of tension pneumothorax is a clinical diagnosis, and it is defined by obstructive shock. Number 3. For imaging, ultrasound, especially finding the lung point, is more sensitive than a supine chest X-ray. Number 4. For anesthesia, you must never use nitrous oxide. And number 5. For management, any pneumothorax in a patient who is about to undergo IPPV requires a chest drain first. Oh, and number 6. The immediate treatment for tension is needle decompression in the 2nd intercostal space.
That feels like a very solid 20-mark answer.
It covers the basic science, the clinical skills, and the critical anesthetic management. If you can deliver that with confidence, citing sources like Miller and Das, you will pass this topic with flying colors.
That was an incredibly high-yield review. To our listener, good luck with the Gujarat University exams. We really hope this helps. We know you've got this.
Stick to the sources, keep your head cool in the Viva. Good luck.
We'll see you on the next Deep Dive.